Good morning, dear professors. What about pseudophakic retinal detachment? Its incidence ranges from 0.6 to 1.7% during the first year, with an overall incidence of 0.7%. It was calculated that at 10 years, the risk of pseudophakic retinal detachment is 5.5 times higher in patients who underwent cataract surgery. Also, it was reported that the cataract surgery increases the risk of retinal detachment at least fourfold. But it differs its incidence, of course, between different surgical techniques. Regarding intracapsular cataract extraction, it is 1.1 to 8.1%. After extracapsular, it is 0 to 7.5%. After extra and phacoemulsification, it ranges about 0.7%. What about the risk factors? Can be classified into preoperative, intraoperative, and postoperative. Regarding the preoperative risk factors, the male sex was found to have higher incidence compared to the female sex. Also, younger age group, also high myopia and history of retinal detachment in the fellow eye. It was found that patients with axial lens greater than or equal to 26 millimeter was 6.5 times higher compared to those with shorter axial lenses. Also, it was reported that 1 millimeter increase in the axial lens was associated with 1.3 increase in the risk of retinal detachment. Regarding the intraoperative risk factors, it is abbreviated into vitreous loss and posterior capsular rupture. Posterior capsular rupture, of course, is the strongest risk factor. It increases the risk about 10 folds. With or without vitrectomy, but of course with vitrectomy the incidence reaches about 34.5% compared to 4% only without vitrectomy. Also, the time to pseudophakic retinal detachment is significantly reduced with vitreous loss and vitrectomy. Regarding the postoperative risk factors, it includes YAG posterior capsulotomy. It increases the risk about 4 folds. Also, vitreous incarceration in the cataract section. What about the pathogenesis? After cataract extractions, we found the most important change is anomalous BVD leading to retinal tears and retinal detachment. What is the difference between what happens between the anomalous BVD and the normal BVD? Normal BVD process is associated with weakening in the adhesion between the vitreous cortex and the internal limiting membrane, with concomitant decrease in the vitreous cortex. This is a slow physiological process that leads to normal BVD. However, after cataract surgery, what happens is that there is decrease in the vitreous viscosity without concomitant dehiscence of the vitreous cortex ILM adhesion, and this leads to tractional forces and, of course, retinal tears and retinal detachment. What changes the vitreous viscosity after cataract surgery? The vitreous content of the hyaluronic acid, of course, it changes. Following intracapsular, the hyaluronic acid diffuses in the anterior chamber, leading to decrease in the vitreous viscosity, while after extra and phacoemulsification, there is modification of the particle size distribution and the viscosity in different regions of the vitreous, so that the vitreous near the retina becomes higher in viscosity than the anterior vitreous, which is a reversal of the normal situation. After YAG posterior capsulotomy, after YAG posterior capsulotomy, there is a lot of mechanisms. First is direct damage, which is an unlikely contributing factor. The second, which explains only the occurrence of retinal detachment in a few cases, is that opening in the capsule with anterior displacement of the vitreous, leading to herniation of the vitreous in the anterior chamber and subsequent BVD with retinal detachment. But this occurs only in a few cases because not all cases are associated with vitreous prolapse in the anterior chamber. The most accepted mechanism is that the laser burst produces a short shock wave known as the acoustic transient, which leads to scattering of high velocity particles into and through the vitreous base, leading to retinal tears and retinal detachment. What about the characteristics of pseudophakic retinal detachment? If we compare it to the phakic retinal detachment, pseudophakic retinal detachment is associated with less likely to have vitreous hemorrhage, as it is associated with smaller number of breaks, smaller breaks than with phakic retinal detachment. Also, 3 and 4 quadrant retinal detachment were more common in pseudophakic patients. Macula involving retinal detachment. Last slide. Macula involving retinal detachment was more common in pseudophakic than in phakic. Most common site in both is supratemporal. However, supratemporal breaks are less in pseudophakic compared to phakic. Inferior and infranasal breaks are more common in pseudophakic retinal detachment. This may be associated because the phaco wound is, or the extracapsular wound is usually superior or temporal. So the vitreous traction usually is exerted on the inferior retina. Retinal breaks tends to be smaller and peripheral in pseudophakic retinal detachment. Retinal breaks are more commonly oral at the aura and less commonly equatorial in pseudophakic retinal detachment. Thank you.